Hi, everybody. Good afternoon. Welcome to the Oregon Health Authority's COVID-19 webinar series for healthcare providers. This is Dana Harganani, Chief Medical Officer for the Oregon Health Authority, and I am joined here by Dr. Tom Jean, the Deputy State Epidemiologist, and Dr. Ariel Smits, our HERC Medical Director. This is, hopefully all of you clearly got the message that we were hosting this on the 5th Thursday. We were lucky to have an additional one. So we are pleased to update you on a lot of information today. We're going to keep an eye on questions, but we're also going to try to fill up the hour with some important updates. Just to give you a sense of our agenda today, we're going to give a brief situational update about COVID-19 and point out some notable trend changes, I think. Perhaps where you're all interested today is to learn more about school reopening and new metrics that were just shared this week. We'll briefly touch upon a new testing site locator website that we've launched, some funding for community-based organizations in their support of our COVID-19 efforts. We'll dive into some national and OHA guideline and guidance updates, and then bring to you a little bit of literature updates and answer some of your questions from past sessions. So bear with us during this busy session we'll bring to you today, and we'll look for your questions along the way. So to start our situational update here in Oregon, this data is as of yesterday, where we had now a total tally of 17,721 total cases. A small subset, as you see, of those are presumptive cases. Again, those are people without a positive PCR, but who have COVID-like symptoms and had close contact with a confirmed case. As those people get testing, they may no longer be presumptive and land in our actual test positive cases. Unfortunately, we've seen a continued uptick in deaths in Oregon, tragically, and we are now at 311 deaths. I'll point your attention to the epi curve picture we have here to give you a sense of what we're seeing in these trends. We're going to share a little bit that maybe in the next slide that helps to indicate perhaps maybe a plateauing of sorts or a slight decline in some of our cases. And this epi curve, as usual, focuses on the new onset of symptoms for cases. That's the date that they show up on this epi curve. The dark blue line shows the proportion of cases that have required hospitalization, and the light blue bar at the end is too recent to weigh anything on those, since that is a case investigation still collecting data. So a little bit more on this next slide. For our last week, our weekly updates are posted on Wednesdays. So the week of July 20th to 26th, we had over 42,000 people tested for COVID-19. We continue to be able to keep those numbers up. And during that week period, we had 2,200 new cases, which is a slight decline from the prior week. And this is the first week-over-week decline in new cases by a very small margin. Since really earlier back in May. And I think we're all hopeful and optimistic that this might be a trend that is persistent. The percent positive weekly test has also decreased for the first time since late May. And I pulled out from our testing report that comes out on Mondays a little bit of a vantage point again for you to see what the trend lines have been. I took us back to mid-May, where we had our lowest percent positivity rate of all of our weekly tests, back at 1.6%. You can see since that time, under the total results, we've been able to increase our testing capacity. And although we continue to have some constraints there, we've been able to maintain a relatively high testing capacity. And we peaked at our percent positivity rate over a couple of weeks here in July. And again, for the first time, saw a decline in the percent positivity since May. All of that, again, is some area for some hopeful optimism. I'm going to pass this off to Dr. Jean now.
Thanks. So this is our one of our public health indicators here on the percentage of COVID-19 cases not traced to a known source. And we've got a target there is the red line of 30%, and you can see that it has been gradually creeping upward. I wouldn't put too much into the last couple of bars there that are really high, because those may be reclassified as we complete investigations, but it is certainly trending upward. So that's consistent with increasing and widespread community transmission. I also wanted to clarify that this does not mean that for these cases that are identified, that we're not able to trace contacts. We still are making every effort once we identify a case to trace their contacts. But this is showing of the new cases, how many of them were traced to previous contacts that could explain their case. All right, next slide is our age group distribution for our cases. And it continues to be consistent with a lot more cases in the younger age groups. Cases are highest in the 20 to 29 cohort, followed by ages 30 to 39, and then 40 to 49. And at this point, the 10 to 29 age group, or 10 to 19 age group, has surpassed the 50 to 59 year age group. So consistent with more people, younger people being tested, more mild illness in general, and perhaps the older, higher risk population staying home and isolating more. And this is another of our indicators on our active monitoring capacity, percentage of COVID-19 cases with follow-up. This is public health follow-up initiated within 24 hours. And a bit of a decline here as well. Again, with the widespread transmission, our public health capacity is being stretched thin, even with all the hundreds of new staff that we've hired. So keeping a close eye on this as well.
So another thing that we've been continuing to share with you and show you is the trends in COVID census at our hospitals statewide. This particular slide is related specifically to those COVID hospitalized patients who've tested positive and trends over time. As we've noted in recent weeks, we've seen an upward trend in COVID hospitalizations, but perhaps over the last week, some level of kind of stabilization. We're continuing to monitor this closely, and our hospitals continue to report adequate hospital capacity. You can see here additional trends we've been monitoring, that over time since the beginning of this pandemic, a smaller proportion of hospitalized COVID patients have required ICU level of care and mechanical ventilation. We've also been hearing reports back from our hospital partners that hospital stays have been shorter, all which are additional good signs as we continue to support the needs of Oregonians with COVID. All right, a hot topic for you all that Dr. Jean's going to walk us through.
Yes, so school guidance, school reopening guidance, and our new school readiness metrics. So OHA has been working closely with the Oregon Department of Education for several months now on school reopening, and they are now in their, I think, third or fourth iteration of their guidance, which is called Ready Schools, Safe Learners. There was an update, a major update last week, and then a minor update this week. So I wanted to highlight some of the major changes in the school guidance. And first and foremost among that would be that now face coverings will be required for students in kindergarten and above, as well as all staff. And there are certain accommodations noted in the guidance, in terms of students with disabilities. And I'd also note that the use of face coverings doesn't change any of the physical distancing requirements that are in the guidance. And there's related to this, the ODE recognizes that families, schools, and community organizations have roles in preparing families and caretakers to prepare children to wear face coverings safely and effectively, including instruction on how to properly wear face coverings, support for getting used to wearing face coverings for younger children, proper care and cleaning, and face covering breaks during instruction. And then again, the protections and accommodations for students with disabilities. So all that is delineated in this guidance if you'd like to have a look. Secondly, another major update is some new firm limits on cohort sizing and a more clarification on cohorting as a risk mitigation strategy. So we know that limiting the number of exposed people to COVID-19 is important, and so having smaller cohorts is important for that. It also allows us to quickly identify the exposed individuals when a case is identified, and can minimize school-wide disruptions in learning. So the absolute limit is that through all the multiple cohorts that a student might have, for example, especially in a high school where they have multiple classes and different cohorts, the maximum total cohort that can be allowed is 100 people, but obviously lower is better. And so that is also explained in detail. Thirdly, the guidance now clarifies the roles of local public health authorities, school districts, and state leaders in determining when to close a facility. The ultimate decision is down to the school district in close consultation with local public health. And then finally, the updates, there are updates to the exclusion criteria, so excluding kids from school and staff if they are symptomatic or have a positive test. And that just aligns with the CDC guidance change that we will be talking about a little bit later. It's now going to be 24 hours after fever is gone instead of 72 hours after fever is gone prior to returning to school. So some major changes to the guidance itself. And then the next slide, I'll go through the school readiness metrics, which were unveiled earlier this week, I believe. So there are three major things to look at for the metrics. So the first is kind of the first threshold would be what is required for schools to return to in-person instruction, including either a hybrid model of on-site and online or fully in-person. And these are the metrics that we'll be looking at. So first of all, at the state level in Oregon as a whole, the COVID-19 test positivity rate needs to be less than 5% basically over a weekly average for 3 weeks in a row. And then at the county level, the test positivity also needs to be less than 5% weekly average for 3 weeks in a row, and less than 10 cases per 100,000 population in that county over the previous week. So that's the first kind of gating threshold. There are some exceptions to that, and these would be, assuming that that COVID-19 is not actively spreading among the school community, and a couple of other requirements. Schools can offer in-class options for students in grades K to 3, recognizing that younger students get the virus at lower rates based on some new evidence we have. They get less sick, and they seem less likely to spread the virus than older children or adults. And younger students also need access to in-person instruction to build some critical skills for literacy and numeracy and skills critical to their early learning. So that's number one. Number two, remote and rural school districts with less than 100 total students, as well as remote and rural private schools with less than 100 students, can offer on-site instruction. And then thirdly, school districts can provide limited on-site instruction to students with disabilities or other important instructional needs, such as career technical education. Okay, so those are some of the exceptions, and that first one was really requirements to get back to in-person education. Number two here is what schools need to be thinking about if things start to get bad again once they're doing in-person learning. When do they need to start planning to transition back to remote distance learning? And so this is kind of a threshold in the other direction. So it's really at the county level, once cases get above 20 cases per 100,000 population over the previous week, and once the COVID test positivity in the county, and this is the county as a whole, it's not specific to the schools, the test positivity is at greater than 7.5% over the previous week. So that's the planning stage. And then number three would be if they hit this threshold, next slide, if they hit this threshold, 30 cases per 100,000 in the county, or a test positivity above 10%, that's when they need to actually shift to fully remote distance learning.
So Dr. Jean, there's a question coming up that I thought maybe we could pause for. I'm noting multiple questions will be bringing them into the discussion, kind of along the right timeline for these points. But the question here is, please address where the school readiness metrics originated and what the evidence, and with what evidence for those thresholds. And the concern regarding limited availability of tests, which means fewer less sick individuals likely to be tested, thus higher % of positivity.
Okay, great questions. So we looked at a lot of the other countries around the world that have successfully reopened schools already, and we looked at what kind of case rates and test positivity rates they had when they reopened. So that was one of the main criteria that went into this. But to a certain extent, it's going to be, these are somewhat arbitrary decisions, just looking at the totality of other examples out there. So if you look at the green text in the Ready Schools Safe Learners version, I think we have a link to that, but if not, if you just go to the ODE website, you can see it's right on the front page. They actually list a table with those other countries and their case rates when they reopen their schools. So that was one of the primary points, and you can have a look at it there. And then the second question was about concerns about test availability.
Just if there's limited access to testing and we're really only have adequate capacity to test the sickest people, how will that affect our % positivity and then influence school reopening?
Yeah, so if that does get to be a more of a severe shortage in testing, that's going to have the almost certainly going to have the effect of increasing our test positivity, because we're testing more sick people and fewer people without symptoms, and so that would actually make it harder to meet these criteria. So
I'd say right now we've been able to maintain a fairly high number of testings despite some constraints out there in supply. So I think this is an area we'll all keep a focus on. And we know one of the primary impacts of our shortages have been a delay in result return rather than seeing an overall significant drop in testing. But a really good point that I think we're all going to be paying close attention to. Yeah,
and the slide that you showed early on, we are still up near 40,000 tests a week, which is great. So. Okay, thanks for the questions. Moving on to a different topic here. Briefly wanted to highlight our new website testing site locator. And this is, here's the link at the top of the page. This is basically something that we have partnered with Google and some others to help make it pretty easy to find local information about where testing is available. So you can go to this site and you can type in your location and it'll show you all the testing sites that are available, and once you find one, you're still recommended to contact the site to make sure that testing is occurring and that they have availability. But it does make it significantly easier to see what options are available in your neighborhood or town.
Great. Another topic we want to bring back to you, certainly in reflection of the disproportionate impact of COVID-19 on communities of color, indigenous populations, we, OHA, in coordination with community partners and local public health, have really focused on investments that can bring our community partners able to provide more resources in our COVID-19 response that are more culturally and linguistically responsive to the needs of community. I shared the application and the intent for these funding opportunities probably a month ago or so, and OHA just last week announced the launch of this program and the funding. So again, this is a program to fund work by community-based organizations to help respond to COVID-19 in culturally and linguistically responsive ways across the state. We will be providing at minimum 173 CBOs with over $9 million of CARE Act funds. And the funding will be to support activities to be taken on by these CBOs in one or more of the following ways: to provide support in communities regarding outreach and community engagement, contact tracing together with local public health authorities, and or providing people with social services and wraparound supports. We're really pleased that we have organizations located in every county in the state that will receive funding, and they have deep ties to the communities they serve. I will say that we know that there's still some gaps, perhaps in depth or breadth of the resources that can be provided in some counties, and therefore there still are an application open process to be able to help fill those gaps. And so you can find out more about both the list of CBOs that we are contracting with and the ongoing application opportunity to fill any additional gaps on the website that we have listed here. You can also go to our news release to learn more about the launch of these programs. We'll continue to bring more learnings from this important work as we go in the future. So now I'm going to pass it to Dr. Smith to tell us about some national guideline updates.
Great, thanks, Anna. So the first guideline update is the CDC has changed their guidelines for isolation and quarantine. One of the most important things is that they no longer recommend a test-based strategy for discontinuing isolation. So if you get requests from patients who want a test to see if they can go back to work or whatever, it's no longer recommended. What they do recommend is that for patients who are symptomatic, that they've had at least 10 days pass since symptom onset, and, next slide, 24 hours since their last fever. You saw that in one of Dr. Jean's slides earlier, where we've made a change in the educational guidelines, and this is the underlying basis for it. So basically, more than 10 days since symptoms started, 24 hours after fever has gone away without any medications, and their symptoms have improved. They no longer say respiratory symptoms because there's an ever-expanding list of symptoms. So if a person had a positive test but never had any symptoms, they can discontinue isolation after 10 days.
So we received a question online that asked us to discuss the data which led to the change of the CDC guidance on when isolation can be ended. For example, 24 hours, as Dr. Smith just outlined, as opposed to the prior 72 hours. And I can share my understanding and ask the team to weigh in if they have any additional comments. In the update to the CDC guidance, they actually shared information about why this change was being made. And my recollection, not having it right in front of me, is that they were looking at the research showing that really after 10 days, there's very minimal viability of the coronavirus particles. And so it was really that with that intention that the decision was made that the transmissibility of infection after 10 days is really very low, if not negligible. And I will go back to one slide where there's an exception here. Do you want to talk about that, Dr. Smith? Because I think that was one of the exceptions with regards to this transmission concern.
Yeah, so for patients who were symptomatic, if they're continuing to be symptomatic or they're might be otherwise high risk, that might work in like a high risk setting, like a skilled nursing facility or something, there may be a case to extend their isolation to 20 days after symptom onset. And you may want to consult your local public health department about that.
I think that would include people with immunocompromising conditions.
Yeah, that was a specific call out from the CDC. Or people with immunocompromised conditions may potentially transmit a replicable virus after 10 days, and that's why this particular call out was made. Great.
On to the Remdesivir.
Yeah.
So on July 24th, the NIH issued a set of expert guidelines on remdesivir use. You'll all recall that remdesivir is an antiretroviral that's shown some promise in treating COVID. The supplies are limited, so the panel recommends that the remdesivir supplies be prioritized for patients who basically are a little less sick. The patients who receive supplemental oxygen but not high flow, they're not on mechanical ventilation, and that they didn't find sufficient data to use it for or against using it if you have mild or moderate. So you're not requiring hospitalization or not requiring oxygen. So this would be if we can come up with that way to do it as an outpatient, like intranasally, or if a patient might have real moderate symptoms in the hospital. Next page. And then if you are on supplemental oxygen, they recommend that you do 5 days or until hospital discharge, whatever comes first. This is a little bit different. They'd had kind of 5 or 10 days, and so they're now kind of narrowing it down to 5 days. And if they do transition to some higher need, like being mechanical ventilation, the 5-day course should be completed. Next slide. If you require high flow oxygen, mechanical ventilation, or ECMO, there's uncertainty regarding what benefit this actually confers for these very ill patients, and the panel can't recommend either for or against treatment. So essentially the panel is saying the sweet spot seems to be those patients who are sick enough to be hospitalized needing oxygen, but not so sick that they need much more intensive care as the sweet spot for if you need to prioritize who should get the limited remdesivir. And then they did say they recommend this 5 days of therapy, but if you haven't shown improvement after 5 days in this group, you could extend it to 10 days.
Great, thank you. I'm going to check in on a question or two here. When we shared the update just a few minutes ago about the updated CDC guidance on discontinuation of isolation, that was specifically for individuals who have tested positive or a known COVID case. The question we have here is, what about people who have direct contact with positive household members but are asymptomatic and have a negative test? How long do you have to quarantine in that situation? So not a known case, but a very close household contact. Dr. Jean, do you want to respond to that?
Yeah, that would be the 14-day quarantine. A negative test, in somebody who's not symptomatic is not enough to say conclusively that you don't have it. So you would be considered a contact, and you'd go through the 14-day quarantine.
Is that 14 days on top of the 10-day of the family members isolation, or from the family members test?
It would be 14 days from the day of last contact during their symptomatic period.
So again, when we're talking about someone who isn't a known case but has had a very close contact like this, for quarantine for 14 days. And just to clarify, the reason for the difference here in the length of time is here we're looking at the science behind the incubation period from exposure to onset of disease, and that's the recommendation both from OHA in alignment with CDC. So great question. One more question that I saw that I will briefly address. Earlier on, someone wrote, do or should Oregon hospital visitor guidelines include recommendations about travel from hotspot states? And I will just say at this time, no, our visitation guidelines do not include screening specifically for travel from other states. We do follow some of our federal guidelines about screening, including at this time, it still requires screening for other high-risk countries. I think we all recognize that there's significant transmission similarly in other states, although that federal guidance has not been updated. I think this is a good point for us to consider. We certainly have been talking heavily with, within OHA and with the governor's office about hearing about a fair amount of case positivity that could come from visitors to Oregon. And so we're keeping a close eye on that. And I think the point is well made here for our consideration. Okay, moving on to some additional OHA guidance updates. This will be quick, but I just really did want you all to know one of our important guidance documents that I think is important for the healthcare community was updated last week, and I just wanted to bring your attention and invite you to take a closer look. This is actually quite a long document and hadn't been updated for many months. This is our clinical care and healthcare infection prevention and control guidance for COVID-19, again updated on July 22nd. I just listed a brief summary of some of the changes that were made in this just to pique your interest for why you might want to visit this. There's more information and updates regarding clinical management and treatment of COVID-19. There's some recommendations for outpatient settings, including focus on patient triage and preventive care visits. This new guidance adds recommendation for the universal use of eye protection for healthcare providers, and I have one more slide to call that out in a bit more detail. It also shares the updates that we just alluded to with the CDC guidance on discontinuation of precautions for those who are COVID positive, and some additional information on return to work considerations within the healthcare field. So we've included the link here as usual. These will be posted after the webinar so that you can come back to that. Diving in a little bit on the universal eye protection for healthcare providers, this is Some new guidance that's coming federally and now also from OHA, really looking at wearing eye protection in addition to a face mask or an N95 respirator, depending on the circumstances. It will allow ensuring the eyes, nose, and mouth are all protected from exposure to these respiratory secretions during encounters in healthcare settings. So specifically, a couple things noted here: due to the increased risk of spread in long-term care settings and the likelihood of exposure, the recommendations specifically call out long-term care facility staff should wear both a mask and eye protection at all times. And in addition, healthcare providers in other settings should consider the addition of eye protection to universal masking, particularly in scenarios where patients are unable to wear a face covering. There's much more detail in this updated document, but really I wanted to hone in on this new. We are definitely hearing that many health systems around the state are implementing this additional change in hospitals, and we invite you to take a look at this recommendation. Okay, Dr. Smits is going to take us into some literature updates, and we'll try to save some time here for some of your additional questions at the end.
Great. So the first study I wanted to highlight, it's been getting a lot of press in the last couple of weeks. It's a South Korean study looking at, it was actually a really, really large study of various contacts of known cases. And it specifically kind of called out that children might be more of a risk of spreading than we might have thought. And I wanted to kind of just get a little bit more information, because the headlines you've probably been seeing in the press are that young kids don't seem to spread this much, but older kids seem to spread it as much as adults. That is kind of a new, there may be a little more nuanced than that. So the children are very rarely the index cases in these. There were very few children under the age of 10. There were only 29 that were the index. They were a very, very small percentage of the index. The index patient would be the patient that first came to the attention of the healthcare authorities, and then rather than being found as part of a contact. Only about 5% of household contacts seem to be positive because of contact with children under 10. And very, very few, about 2% of non-household contacts. So a household contact would be the person who's living in close proximity. Next slide. In terms of the older kids, 10 to 19, there were 124 of those, so 2.2%. Again, a very, very small group, very, very small overall as index patients. But they did have a large percent of household contacts traced to them, so about 18%. And that actually was not statistically different than adults. So the tweens and teens seem to create household contact positivity at about the same rate as adults, but very little of non-household contacts. So the takeaways from this are that school-age children seem to spread it the lowest amount, school-age children were spreading it about the same amount, or perhaps a little more than adults, but younger children had a very low spread. I still wanted to draw your attention to the fact that children were very rarely the index case. There's a lot of questions that this study raises in my mind, one being children are rarely symptomatic, so there may have been more index children, but they were found as contacts once they got someone else sick. So we can't quite tease out directionality from this study. It's kind of more of just a broad swath of population study, but it does raise some questions about sort of the kind of general thought that we had for a while that kids might not be spreading this. Go ahead. And then to kind of piggyback on that, this was a study that just came out yesterday in JAMA, and it's a very complicated statistics in this study, more complex than I really can tease out myself. But basically they did a population-based time series analysis in the beginning of March to the beginning of May. They looked at various non-pharmaceutical interventions. I was really interested to see that term. I'm reading a history of the 1918 pandemic, and that's when they first called it non-pharmaceutical intervention. So we haven't changed much in 100 years. But these would have been shelter-in-place orders, business closures, restaurant closures, etc. They got all of these from they kind of scooped up data from all sorts of states and looked at orders that were published on, et cetera. And then they looked at different state databases, mostly Johns Hopkins, to look at rates of infection. What they found was that school closures were associated with a significant decline, about a 62% decline in overall infection rate and a 58% decline in mortality rates. The associations were largest in states that had the lowest COVID rates at the time of school closure, possibly because, well, there are lots of different theories as to why, but perhaps there was less widespread infection going on at that time. Why don't you go ahead on that? Next slide. So the absolute difference, if you closed your schools, was that your rates went down 424 per 100,000. So a pretty significant impact. They did a bunch of controlling for all of those non-pharmaceutical interventions. That's where all of the very complicated statistics come from, which if you're interested, they have multiple supplements that go through how they controlled for them. And they're basically, the older your population and the more dense your population, the more significant the effect of school closures. They did note that they may not have been able to completely control for these other non-pharmaceutical interventions because a lot of them were co-occurring in time. But it's an interesting study that seems to support that kids may or may not be spreading it, but at least the whole school environment seems to be a place where the virus is spread.
And we had one comment just clarifying and confirming that the South Korean study was conducted when schools were closed, which is accurate. Right. And they call that out in the article yes. As a, of course, limitation in terms of its generalizability and perhaps, could see different outcomes in a different setting.
Yeah, and they specifically called out that the younger kids were less likely to maintain peer interactions versus the older kids. So that might be another reason that the older kids seem to be spreading it more. The younger kids were much more effectively isolated at home. Great. And then the third study I wanted to look at was just a seroprevalence study that came out again in the last week or so. This was a convenient sample. So this is serum collected for various reasons, March through May, in various large cities from 16,000 persons. So these were not necessarily people who were tested for COVID. It was just serum that was collected for whatever reason. And they ended up finding that the amount of seropositivity was very dramatically different depending on where it was 1% in San Francisco compared to almost 7% in New York. Next slide. But overall, they basically feel that our test positivity for when we do PCR or antigen testing for SARS-CoV-2 is 6 to 24 times lower than the actual infection rate. And overall, they feel it's about 10 times. And I think that's pretty consistent with what public health folks have been saying, is that for each case we find we're missing 10. So just an interesting note. And then there's the final study. We talked 2 weeks ago, I had brought you a study looking at hospitalized patients having prolonged persistent symptoms. This is just kind of a corollary. This is a study of initially non-hospitalized, although 7% ended up being hospitalized, but these were pretty mildly ill patients. But when they were contacted 2 to 3 weeks after their test, there were 35% or so still had not returned to their usual state of health, which is quite different than we see in influenza. In influenza, almost everyone returns to their usual state of health within about 2 weeks. Next slide. Is there one more on this one? Yeah. And the most common symptoms were cough and fatigue, shortness of breath. The longest time to recovery was the sense of smell, which I think there's been interesting research about neurologic issues going on with that, so it would make sense. So basically, the older folks also, and people with more medical conditions, had a longer time returning to usual health. So basically, the takeaway, again, kind of echoing the more ill people in the hospital, is that anyone getting COVID, it seems to be a much more prolonged illness than, for example, influenza, and you can reassure your patients that their recovery is on a normal, quote-unquote, path if they're still having symptoms a few weeks later.
So Dr. Smith, there's a question here that I think is timely with regards to this study. We had someone comment or ask what resources are available for patients who are having long-term sequelae and are still incapacitated, having limited access to medical appointments or with specialties, maybe limited appointments due to their COVID status, inability to access an appointment, for example. So any thoughts from your clinical perspective on how one might navigate that?
Well, I know that almost every health system and OHB have really expanded their access to telehealth. And these folks, that's a very good way that they don't have to exert themselves much and can still access medical care. That would be my first thought. And then most of this is really just going to be supportive care at home.
I think also one consideration as medical providers to explore with the insurance provider as to whether there's additional home health services or exceptional need nursing services that could be brought to bear in these situations. I know everybody's really looking how to be more innovative and flexible and how to meet everyone's needs, both in the sense of infection control as well as access to care at this difficult time. So hopefully some of those ideas will be helpful.
So we were very lucky to have Melissa Sutton from the Public Health Division with us last time, who answered almost all of your clinical questions. There were a couple that we didn't get to, and I just wanted to kind of make sure we kind of close the loop on those. One question was, what updates do we have about survival from mechanical ventilation? Early on in the European studies in New York, we were finding that 80% or so of patients who were put on a ventilator did not survive. There was a study at the end, published at the end of May. It was a cohort study just from one academic medical center in Georgia, but their results were much, much better. Their survival rate was about 65%, although 5% were still on a ventilator at the time that they had the report come out. And they noted that there was no correlation with treatment with hydroxychloroquine or remdesivir or anything. And I just wanted to point out, this may or may not be related, but there's new guidelines about avoiding intubation that the NIH has, really focusing on using high flow nasal oxygen, prone positioning, et cetera. And the folks in it was just a short letter basically from this group in Atlanta. But they mentioned that they were using more prone positioning and other types of interventions that may have improved health outcomes.
Another question that came up that I think is timely here, it was related to both the data on mortality, but also thinking about the fact with the seroprevalence data and other resources that suggest we're missing, through our testing, 9 out of 10 cases. So I think the question is around, for example, our case fatality rate that we report on, is that, I'll interpret here, is that an overestimation of the overall case fatality rate of the disease, given our testing capacity and who's actually being tested versus who's might be being missed with this. So my comment would be, I think we have always assumed that our case fatality rate is, yes, limited to those we know who are positive, and we are going to be monitoring all the data as we continue to go through this to understand the real case fatality rate. Dr. Jean, anything you'd add to that?
No, I think as more data comes out on the true number of infections that we've seen, that we'll just continue to improve the estimates of case fatality and severity.
But I do want to point out, it really depends on groups. So over 80 folks, I think we are going to find a continued very high case fatality rate, but maybe for younger folks, it will be lower than what we're seeing.
Mm-hmm.
Great.
And then the second question that had come through was a question about cardiac impacts, and specifically they wanted a look at their new study that came out of Germany. So this study came out actually this week in JAMA Cardiology. It must have been a preprint that was referenced a couple of weeks ago. It was a cohort study of 100 patients who were about 50. Most did not require hospitalization. And of the, basically 78% of these patients had abnormal cardiac MRI findings, What I found really interesting about this study, though, when you looked at the methods, was that they excluded anyone with cardiac symptoms. So I'm not sure what to make of this study. So these are patients who are not complaining of chest pain, shortness of breath, any cardiac symptoms, but they have cardiac MRI findings. So they have lower left ventricular ejection fraction, higher left ventricular volumes of mass, etc. In severe findings of patients, they did have active lymphocyte infiltration. So basically, this shows that this disease does appear to affect hearts. I'm not sure how much this actually affects the overall symptomatology of patients, though. But it's an interesting thing to note, and definitely something to keep an eye on as we learn more about this disease and its sequelae.
So I'm going to bring us back to some questions here that you've been sharing with us. First, I'll note there's been some questions about eligibility around short-term disability unemployment benefits. I think our team needs to do a little bit more digging to make sure we have accurate information about eligibility for those. We've been engaged in those discussions in various ways, but we'll come back with more information to be sure we're giving accurate input on those questions. There was a question asking about an update on vaccine timeline. So I'll share a few comments and see if my colleagues have any additions. I had the opportunity last week to listen into the National Academy of Medicine conversation. That was a public meeting focused, or including the Committee on Equitable Allocation of Vaccine for the Novel Coronavirus, including the head of the NIH and the CDC, among others. And so during that time, and as I think has been shared by Dr. Fauci and some of the media presentations, right now the kind of earliest, most optimistic look at when a vaccine could be ready as early as December and January. And my guess is that that's fairly optimistic, but certainly is what's being shared at this point. I think it's really worthwhile noting that as soon as a vaccine is available, it's not going to be able to meet the entire population needs. So this is why this particular committee has been formed to really think on short order how prioritization of who gets the vaccine in the earliest days and months, how that should be prioritized. We have been following other news about the various vaccines. My understanding is that there's 4 vaccines currently working through their phase trials. And we're hearing some of that in the media as well that you might all be watching. I'm going to open it up. Dr. Jean or Smith, anything you'd add to that update?
Yeah, I just would add that Moderna vaccinated their first U.S. participant for their COVID vaccine trial. They have a goal of 30,000 participants. You can actually sign up if you want to participate, coronaviruspreventionnetwork.org. And then Pfizer started their U.S. trial this week as well, and they're also seeking 30,000 people, and they have a link on their website. So if you want to be a guinea pig, I think you can sign up. It's kind of exciting.
And I would also just add that we, OHA, have been already working to consider kind of, alongside the federal government, how we might make sure that the distribution in Oregon rolls forward smoothly as can be, and consider, what our prioritizations might be, and working towards get some broad community impact, really with an equity focus in this work. So we can share more about that. That is going to be forthcoming and work already importantly underway, as it takes a long time to make sure we get all the right input and plans in place for when that vaccine does hit availability.
I would say vaccines.
Vaccines, hopefully. That's right. That's right.
The more the merrier.
Yeah.
And let's see, there was one other question. Let's see. There was a question back on the guidance update that I shared about OHA and the facial coverings. It was asking if glasses are sufficient, or should it be goggles or face shields. Dr. Jean, do you, or Smith, do you remember what that guidance says about?
Goggles or face shields. Glasses aren't sufficient.
Great, thank you for the clarity. So again, in the guidance for healthcare provider protection around eye protection, not regular glasses, but should be goggles or eye protection. And I did note someone saying that that's happening in clinic, but not in the hospital. Again, take a look at the guidance. It really does include all healthcare providers interfacing with patients as a recommendation to consider. And we are hearing this is a relatively, big change in recommendations. And I know hospitals and health systems are working to kind of update their policies to consider how they kind of can follow through with some of this guidance newly coming out. And we are certainly hearing of some of those policies changing as we speak. I'm going to ask a question also about anything else, and maybe we can just note this for bringing back. We've been looking at this ongoing, but we'll continue to take a look at the literature. The questions are there other information or literature available about ongoing sequelae post-COVID? What are they? So, shortness of breath, headaches, any cognitive impairment, different or the same as the initial symptoms, and whether or not they ultimately resolve or do any of them become permanent. Is there anything else you've seen, Dr. Smits, in the literature?
We wouldn't know if they would become permanent. I mean, this disease has only been around 6 months. It looks like the main ones that persist are shortness of breath, fatigue, and then this loss of smell are the main ones reported. But again, this is a new area with lots of stuff that I expect to come out imminently.
Great. And then Dr. Jean, there's been a few comments made about the use of face shields, and is it appropriate that they're used in place of face coverings or masks to prevent community spread? Some reference to this regarding the education guidelines. I know we at OHA, our senior health advisors, have had a lot of discussion about this topic. I'm wondering if you can share some of the highlights.
Yeah, our guidance is evolving on this as we have been working with an expert in physics or fluid dynamics and looking at some of the case for airborne transmission playing some role for COVID. So currently, I think we still include face shields, but we are starting to emphasize face coverings and medical grade masks as being a better level of protection than a face shield, which of course will not stop aerosols. And in specific to the school guidance, the most recent update still includes face shields, but it's perhaps a little confusing because it talks about face coverings being required for all students, and it defines face covering as cloth, paper, or disposable face covering that covers the nose and mouth. But then it talks about clear plastic face shields could be preferred in some instances because they enable students to see the face and social emotional cues, and also phonological instruction for those purposes. So ODE certainly wants to align with us. So I think the next update may change and be a little bit more restrictive in terms of face coverings versus face shields. But this is an area that is rapidly evolving.
Great. And then I'll just loop back to an earlier topic about the funding for the community-based organizations and just hit a couple high points. There's a question about certified community health workers and their role in the work. And I will just let you know that there are many organizations that employ or will be working with community health workers through this work that I've come to understand. We have also been building out a community engagement team as part of our corona response here at the state in partnership with our local public health authority partners. And so a lot of coordination, training, and other work happening with those CBOs that are coming on board through contracts. This is all a really big lift and really new, and so I'm sure I'll be able to share more information about the structures we're building to support that in partnership with local public health, and more information as we learn about the work underway and the impact that it's having over time. So stay tuned. Another question I'm seeing here in just the last couple of minutes, what about the role of valves in cloth or N95 or other types of masks, such as N95? Can we speak more to that? I believe this is actually specifically addressed in some of our PPE guidance documents. We have a document that's an interim guidance around the use of PPE in resource-constrained settings. that gets into a fair amount of detail. There's also, I believe, just in maybe the last 24 hours, a new dental guidance that's kind of a update and corollary to that, that's specific about dental settings, and some of the comments about valves come up in both of those. Anything you all can articulate here on the spot about the role of those valves and the concerns they might add?
Yeah, well, just in general, the valves are typically found in more of an industrial type N95 mask, and they're meant to make them a little more comfortable because they allow you to exhale more easily, but you're not filtering all the exhaled air if there's a valve. So in terms of source control, they're definitely not as good. So I think we are generally recommending against them.
Great, thanks, Tom. And I will say, being relatively new to some of this area, source control was a little bit of a new term for me, and so that's the intent around some masking, where if you were to be sick or asymptomatic, trying to block the droplets and as you're breathing to limit the risk of transmission to someone else in your space. We've talked a lot about that with the role of masking, and so that's what the source control. If you were the potential source of spread, we're trying to block that, and with the valves that would not be the case, or that protection would be lost. All right, well, we have had a full hour here. Thank you for all the questions. We will continue to bring forward information in response. I'm going to give a big thanks to my team here in advance. I'm actually going to take some time off next week, so you will be brought back next week to our OHA webinar. We'll be back to the first Thursday of the month. As you see here, the second and fourth continue to be our OHSU Echo sessions for clinicians. So we'll see you in these coming weeks. We just again want to give all our thanks to the frontline work that you are all doing in this ongoing marathon and area of stress. I'm sure that for many of you, thinking about the school changes and metrics this coming fall are going to have an impact. So please know we appreciate all the work you do, and I hope you're all finding a little time to relax during this summer month. All right, thank you very much.